speaker is Artem Belyakov, who is an NIH T32 fellow at Thomas Jefferson University.
Thank you for having me here. I'm really excited to present my work that I've been working on during fellowship from start to finish. So let's begin. So population, pharmacokinetics of methadone and pregnancy. Why are we giving pregnant women methadone? So specifically for opioid use disorder in this study, and I want to talk a little bit about the relevance of opioid use disorder in pregnancy. So if we look at the chart in the last decade, drug-related pregnancy-associated deaths have more than doubled. Of course, this decade, things are looking a little bit better, but this is a major concern in our society that we need to be able to properly treat opioid use disorder in pregnancy. There's also other morbidities related to it, so that affects both mother and baby as well. So I want to talk a little bit about methadone. So it's one of the treatment options for opioid use disorder, especially in the pregnant population. So it's a full mu-opioid receptor agonist. It's a highly lipophilic molecule, so a lot of distribution into tissue. It is largely bound to plasma protein, so specifically alpha-1 acid glycoprotein. It's a major substrate of CYP3A4 and CYP2B6, so there's hepatic metabolism. And as well, it also undergoes renal elimination, so about 20%, but still a significant fraction. And at least in the United States, it's administered as a racemic mixture. So I talked a little bit about its disposition. How does pregnancy potentially affect methadone's disposition? So I have some bars here. This is just looking at the change of function in pregnancy compared to a non-pregnant person. And I want to begin with looking at the body weight and fat mass. We see that increases in pregnancy and throughout trimester. So that could affect methadone volume. As well, we see that there's an increase in cardiac output that relates to increased hepatic blood flow, which gives more opportunity for methadone to reach the liver, be metabolized by CYP enzymes. As well, AAG stands for alpha-1 acid glycoprotein, so decreased expression of the carrier protein of methadone. So unbound methadone, more opportunity to be either metabolized or renally eliminated. And on the last two ones, we see increase in GFR, increase in renal blood flow. Again, more opportunity for methadone reach the kidney and potentially be eliminated. So also not pictured, there's an increased expression of CYP3A4 as well as CYP2B6 in pregnancy. So there's a lot of potential factors that pregnancy can affect methadone pharmacokinetics. And hopefully with this knowledge, we are dosing methadone uniquely to pregnancy, taking into consideration all these physiological changes. But unfortunately, that is not the case at this moment. So there are no national obstetric guidelines telling us what is the right way to dose methadone specifically for the pregnant patient. So this is where the bump trial comes into play. I didn't run the trial, but I am using data from the trial. So the bump trial, what does it stand for? It stands for bettering our understanding of methadone in pregnancy. So that's the goal of this trial. So collecting information on what doses were used, what was the stable dose, how long did it take for someone to get to a stable dose of methadone. So this included 30 pregnant patients that got admitted to Thomas Jefferson University Hospital for methadone stabilization. So this is a PK study. What kind of PK data do I have? So drug plasma concentrations were collected right before a daily dose and 4 hours after a daily dose. And this represents more or less a peak and trough concentrations. I have metabolite levels. I also have its primary methadone levels. I also have primary metabolite levels, EDDP, and secondary metabolite levels, EDMP. And in terms of what data do I have available from this trial to work on? So as I mentioned, I have the concentrations. I also have COW scores. It stands for Clinical Opioid Withdrawal Scale, so measure how bad is someone in withdrawal. As well, I have CYP2B6 genotype information and various demographic factors to look at. In terms of modeling approach, so I have dosing data, I have levels, I used Monolix software for the PK analysis. I looked at 1 and 2 compartment models because that's what was done in the literature, as well as I looked at the potential time effect because it was found that methadone actually also has autoinduction, so makes things even more complicated. Since I was working with a parent metabolite model, I had to make some assumptions. Sadly, I don't have urine data to see methadone and metabolite concentration. So in terms of model identifiability issues, I said parent volume equal to metabolite volume. I said parent clearance to 0. And I mentioned peak and trough data does not cover the absorption phase, so I had to make an assumption. I found a study where there was intensive sampling of methadone in late pregnancy, so I just took the number from them since I don't really have a way to estimate my numbers. And I have various covariates I considered, so gestational age, the 2B6 phenotype, demographic information, as well as I had smoking and alcohol status to look at. So this is my model, my final model that I selected. So methadone is one compartment. I have a KA, so this is oral administration of methadone. I fixed that to 1.32. That was the reported value from that previous study I mentioned, since I can't really estimate it myself. Methadone clearance, I set that to 0 just because of my constraints, parent metabolite model. KPM represents the conversion of methadone into its primary metabolite EDDP. This is done only by CYP enzymes. So I have EDP, one compartment, same volume as parent. And then I have metabolite clearance, CLM, and this represents both further CYP conversion of EDDP into EDMP, as well as other clearance processes such as renal elimination. So over here, my model parameters and covariates. So I have some numbers that I was able to get. Ka, again, I didn't measure that. I have a volume and distribution of 230 liters, which is expected. Methadone is a lipophilic molecule, so this is along the lines of what I expect. Parent clearance I didn't estimate. I have also values for metabolite clearance as well as KPM. And the two covariates I ended up including in this model includes gestational age on KPM as well as CYP2B6 rapid metabolizer status on KPM. So basically, CYP2B6, are you a rapid metabolizer or are you not? That's how I set up that covariate. And as well, I have a prediction-corrected visual predictive check. I want to point out this is time after last dose. This is very messy. Some patients, I only have 2 concentrations. Some patients, I actually have 16 concentrations. So it makes it a bit more complicated as well. Between daily doses, some people were able to get as-needed methadone doses, so not very clear-cut. So I just set it time after last dose to kind of equalize everything. And on the left-hand side, that's my methadone table chart, and I see a great fit, and as well a good fit for EDDP on the right-hand side. So my model is able to capture my data pretty well. So challenges and next steps. So several things I want to point out. I wasn't able to estimate absorption in this population. So pregnancy affects GI transit time, and as well active opioid withdrawal can also affect GI transit time. So nausea, vomiting, diarrhea. I'm not able to capture a unique absorption value for this population. I mentioned methadone is an enantiomer, is a racement picture of enantiomers. I only have racement concentrations, but that is relevant since CYP enzymes have different affinities towards different enantiomers. As well, R-methadone is responsible for the opioid effect. S-methadone is responsible for the QTC prolongation, so it's possible that these two enantiomers are acting differently, but I don't have the concentrations to see that. I mentioned as well model identifiability issues with the metabolite. I don't have urine data, so I can't find out the true metabolite volume, for example. I was missing a lot of hepatic and renal values, which made it hard. It would have been really nice to look at that as a covariate, but at the same time, this population, I didn't have any severe renal function dysfunction or severe liver dysfunction, so I don't know how useful it would have been in my situation. And extrapolation, this is methadone new start patients only, not people that are stable on methadone. In this situation, methadone was given as a liquid, but usually it's given as a tablet. Bioavailability of methadone is about 90 to 100%, so it might not make a difference, but I can't say for sure based off the study alone. And I only included 30 pregnant women. I didn't include any non-pregnant women or men for that matter, so I'm not able to make any direct, this effect is solely because of pregnancy. So that's another concern. Next step for this model, I have that opioid withdrawal scores available every 4 hours, so that would be a nice connection. So methadone concentrations, how well is it treating opioid withdrawal? That's what's relevant for clinicians, and that's my goal of this model, is to be able to tie a specific concentration as well to efficacy in treating withdrawal. But it gets tricky since there's also other medications being given at the same time to try and handle withdrawal, Tylenol, antiemetics, muscle relaxants, all that. So acknowledgments, lots of acknowledgments. I want to thank the team. I want to thank the NIH for the fellowship and as well MPRINT. So MPRINT actually funded the trial. So I'm really happy that I'm able to bring it full circle and present my analysis on the work. So lastly, I want to thank the bump trial participants. They're very courageous on signing up for research while undergoing withdrawal. So hoping that my work is able to improve the lives of other women that are pregnant with opioid use disorder. Thank you.